All right, just by show of hands, how many people work at a trauma center? Level 1, level 2, level 3, so a fair amount. Okay, no cheating. Don't look at your paper here. What do you think it costs to have a trauma activation? $20,000, $25,000. Kind of trick question. It depends where you live. So back in 2002, the government decided, yeah, we should probably pay hospitals to have a trauma activation fee, because it's expensive, right? You have to have your trauma surgeon, an orthopedic surgeon, anesthesiologist, OMFS if you're a level 1. And these poor hospitals, regardless of whether a trauma came in or not, right, has those costs. But then they also passed a couple years ago a rule that every hospital has to have a charge master. So it's publicly available how much you charge to, say, have your gallbladder out or your appendix out. So this is a study that looked at what are the trauma activation costs and what kind of factors are associated with higher costs. And they found the mean was about $13,000, but the range was all over the place. For a level 1, it went as low as $1,000 and as high as over $60,000. And they're kind of pointing out that this is kind of insanity, right? Like someone who is brought in by an ambulance with no control, like they take them to whichever hospital, may get disproportionately higher costs depending on where they're brought. And what were the factors associated with that? Well, one, if you're on the West Coast, it's going to be a little bit more expensive. Interestingly, if you were brought to a level 2 trauma center, it was higher cost than if you went to a level 1 on average. Why do you think that is? Anyone ever heard of HCA or work at an HCA hospital? HCA is the largest for-profit hospital system. They have generally much higher costs than the academic centers, which tended to be more level 1. So the factors, again, these are associations, as Ken just talked about. They're not a causation, but associations were on the West Coast if they were a level 2 trauma center and if they were for-profit. And I think it's interesting at my hospital, and I work at a military hospital, so we were excluded from this, but hospitals are sort of incentivized to keep your trauma levels up, right? If you don't see X amount of traumas, they take your trauma status away. So we would have like a 10-year-old who fell from standing, and somebody would say, well, that's a trauma, right? And then they get this $30,000 bill. So it's raised a lot of national attention, and the authors here are kind of calling for this transparency, but also some standardization so that you have somewhat similar costs. But I recently moved from San Antonio, Texas to San Diego, and the cost of living, right, a little bit different. Anyone want to know what the cost of gas is in San Diego right now? It's about $6 a gallon, yeah. So it is a lot more expensive to pay an orthopedic surgeon or neurosurgeon to live in San Diego. So I think there should be some geographical cost index, but $60,000, it seems like a lot.
It is. And you should see our faces from California when we drive by the gas stations here. We're all $3. Wow, this is amazing. Yeah. So this whole, all of this came out in 2002 because, and it's justified, right? You have these trauma centers where you're staffing 24 hours, you have to resource up, and those hospitals will go out of business if they don't have any sort of funding for all of these trauma team activations. And we over-triage a little bit because we want to capture the sickest patients, but this has come at a cost over the years with this like big variance in cost, and you see it on the patient side. We're talking about it on a systems level, but when you read some articles and anecdotes about how this affects patients, there was a story back, I remember the first time hearing about this, somewhere around like 2016, 17, there was a case at UCSF of an 8-month-old that had traveled from Korea, had ended up like at the hotel room, and the baby fell off the bed and hit a carpeted floor. Was crying, was inconsolable, went to the ED. They did no tests, no nothing. They observed, put the baby in the mom's arms, and went home. And they got a $18,000 bill. And $16,000 of that bill was for this trauma team activation cost. It is a huge amount. And so this type of variation is not just potentially problematic on a systems level, but also for an individual level. I mean, just billing practices across. We could talk 30 minutes about all the variable billing practices. So let's go into another logistical thing. On abstract number 2, this is a paper about emergency physicians versus trauma surgeons being team leaders in these traumas. So true or false? Can an emergency physician be a trauma team leader? Well, according to ATLS, the answer would be no. The ATLS recommends that surgeons serve as the trauma team leaders, but as we know, whether you're working at a trauma center or a non-trauma center, emergency physicians are often the people that are receiving all of the patients that come in as MVAs, get a penetrating trauma. And so are we as effective? And so the authors of this paper wanted to take a look at outcomes based on who was leading the team. So this is a database review of 6 level 1 trauma centers in Canada, looking at surgeons versus non-surgeons leading these teams. It was an observational chart review without a lot of the methods that you typically want to see out of a chart review. But the data was interesting. They had about 13,000 adult trauma patients, and out of those 13,000 patients, they looked at if a surgeon led the team or if an emergency physician led the team, what was the in-hospital mortality? And they found that the numbers were about the same once you adjusted for illness. They found that when surgeons were leading the teams during the day, they tended to see slightly less sick patients, and then the emergency physicians that were working overnight were seeing a lot more of the penetrating traumas, so there was a little bit of a disparity in how sick the patients were. But after adjusting for those variations in illness, the mortalities were right around 12% in both groups. So the bottom line here was that emergency physicians should be able to lead traumas just the same as surgeons.
And I think this paper was already tilted in favor of the surgeons. They said 38% of these patients went emergently to the OR. So what happens if you're the trauma surgeon, you're running the surgery, you go right up to the OR, right? Those patients get brought up to the operating room within minutes. On the teams where the emergency physician was leading the team, now they have to call in someone from home to come in to go to the OR. So even if the best case scenario, the rates are the same, they're saying that because of that inherent delay when an emergency physician is running the trauma, the outcomes are still the same. So I think this suggests we're probably even better, but the surgeons don't want to publish that. All right, the third study looks at, do alcohol and drugs affect vital signs? So Ken talked about, got to be careful when they exclude patients. And I will just say right off the bat, this study excluded 90% of the patients who were eligible. So that kind of makes you wonder, why did they even do the study? But their question was a good one of how much does alcohol or drug tests change a patient's blood pressure, their heart rate? Can we attribute some of those abnormal vital signs to being intoxicated, or is there something else going on? And what they found essentially was that there wasn't a whole lot of difference. The systolic blood pressure in people who had positive alcohol or drug levels was 133 versus 143. If they were on benzos, it was 134 versus 144. And the heart rates were similar, 88 to 98 for any type of group. Do we have any toxicologists in the audience? Right, they always hate tox screens because the problem with tox screens is you can be positive for marijuana even though you did it 3 days ago, right? A lot of these drug tests don't pick up every drug test. Alcohol levels are a little bit more relevant. But the point here, their conclusion, I think is right, although it's not really based on this data. And their point here is that you should never attribute abnormal vital signs to alcohol or drug use, that there probably is the underlying trauma. I don't think this proves it. Again, they excluded 90% of their patients. Their methods are very, very fuzzy. But the bottom line is, if they have abnormal vital signs, it's probably not just because they're drunk. There's probably something else going on.
And then abstract number 4 is about the clinical exam sensitivity for traumas. So this is a kind of a neat little paper that was done out of the UK. They were basically looking at, does our physical exam in traumas correlate to severity of illness and life and limb-threatening injuries? The way that this study was done, it was done out of the UK, where they have it was called the London Air Ambulance, where they basically either drive or fly out to all of the traumas and bring them back to the trauma centers. And the way that this differs from the States, anybody from the UK? Yeah? So this is different than our system, where the ambulances actually have a physician on board. And that physician could be a trauma surgeon, could be an emergency physician, an anesthesiologist, but they will go out to the trauma, and then the documentation run sheets from the study, they had to write the physical exams. And then the way that the chart review was done was they looked at how those physical exams subsequently compare to the reference standard of radiographic findings, operative findings, actual injuries. And they wanted to see what the sensitivity of the physical exam was. So, and then they looked by anatomic region. They looked at for head trauma, for chest trauma, abdominal and pelvic trauma. What was the sensitivity? And they looked at about 1,000 patients. What they found was the sensitivity of the physical exam was, no surprise, not great. So for head trauma, it was about 70%, chest trauma, 59%, abdominal, 52%, unstable spine, 15%. So this sort of begs the question of two things. One, how do we supplement our physical exam during traumas, either through clinical decision tools or, as some trauma surgeons, or depending on where you work, advocate for, is do we just pan scan all of these people? And I don't think the answer is, based off either this paper or the body of literature out there, is that we need to pan scan everybody, but we do need to understand the limitations of a physical exam in identifying limb and life-threatening injuries. The worse the mechanism, the more elderly the patient, the more likely we are to see a call to injuries, and the more likely I am to scan patients. But this is just one more paper kind of that solidifies that our physical exam just isn't good enough for a lot of these sicker traumas.
I said I think in a few years we're just going to have a conveyor belt through triage. You get your pan scan on the way in and then your work note on the way out. We don't even need to see the patient, right? This paper frustrated me because it sort of justifies doing the pan scan. I thought we were better than that. And even in this head injury, which you would think, I mean, patients have abnormal neuroscience, they have a blown pupil. Even with patients with proven head injuries, the sensitivity was only 70%. So when I first read this, I thought, well, maybe this is because it's pre-hospital. And I used to be an EMT. I know how difficult it is to try and assess people on the back of an ambulance that's shaking driving down a curvy road, that maybe if it was in the emergency department, we'd be better. So abstract number 5 looks at patients who now come into the ED. So this is no longer pre-hospital, but actually in the emergency department. And it was a survey. And they found all these patients are going to get scanned, but they asked the doctor and they asked ED attendings and then trauma and ED residents, what do you think? What do you think are the odds that they're going to have some significant injury that requires some sort of an intervention? And just give us a scale. Do you think it's high? Do you think it's moderate, meaning an 11 to 20% risk? Do you think it's low, like a 2 to 10% chance? Or do you think it's really low, like less than 2%? And then we'll see what their CT shows and we'll see how good we are. How good do you think we are? Generally not very good. So even in the group who was low, they thought less than 10% chance of having something, sensitivity was only 75%. So we were missing a quarter of patients who may have some critically intervention that required some sort of procedure. And even in the very low, where they said, there's nothing wrong with this guy, right? This is less than 2%. The sensitivity was only 95%, which sounds good, sort of, but you're still missing 5%, which is higher than that sort of minimally acceptable risk in emergency medicine. So this is a little scary that maybe we should be a little bit more understanding when the surgeons want to pan scan everyone. My criticism with this one, though, is they didn't break it out by mechanism. And the one that drives me insane are when the patients fall from standing, and I'm not talking about the 90-year-old who's on warfarin. I'm talking about like someone our age who fell, tripped, hit their head, didn't lose consciousness, and they're like, we need a pan scan, we need a CT, the chest and the abdomen. I'm like, that's insane. They have no chest pain, they have no belly pain. Like, can we just do the head if that's what you're concerned about? And they didn't really answer that in this paper, and I would love to see that published of these very low mechanism, low risk patients. Are there at least some subset of patients that we can get away from the pan scan?
Yeah, like that less than 2% pretest probability group, I think they're not all created equal. And like Gillian saying, there's certain people where this is where the art of medicine is. Even if you're looking at the paper and the data showing 95%, we know as clinicians seeing the patient right in front of us that there are certain people you just don't need to scan. This does not justify scanning the young patient that trips over because the data shows that our 95% sensitivity in that low risk group is true. And then in terms of clinical decision tools, this is interesting. We talked about the sensitivity of the physical exam not being fantastic, and we're talking about our pretest probability not always correlating. But I do want to remind all of us that, like for head injuries, we do have good clinical decision tools. The New Orleans, Canadian, all those, they tend to be pretty good. And I think that those can be applied in the certain populations. We don't have great clinical decision tools yet for chest trauma, abdominal trauma. And so when there is sort of that moderate risk or they're not that clear-cut person, those are the ones where I think CAT scans can have a role.
Great.
All right. How about, besides vital signs, besides physical exams, what else do we have in trauma? We have the FAST. And in this next paper, abstract number 6, they talk about the EFAST. Does anybody use the EFAST in their practice? The extended fast? Okay, so I see a handful of hands. I'll tell you, they're going to talk about the clinical performance of the EFAST and making clinical decisions. This is a paper that was done out of France. But I first want to kind of talk about what the EFAST was in this study. When we do an EFAST, I don't know what the components are for the EFAST where you do, but we do the typical fast and we do the lungs.
Yep.
The EFAST in this study was extended even beyond that. They added on a fast of the pubic bones, to look for pubic symphysis widening, and they did a transcranial Doppler, which is certainly not something that I'm using as a matter of routine, but they did have, that was part of their standard EFAST. So I just want to kind of frame that before we, as you're interpreting these results. But this was a prospective study out of France. They basically looked at about 500 patients at 6 trauma centers that were getting EFASTs. And they looked at, based off the EFAST results, if the clinician decided to make a decision about some sort of intervention. And the different interventions included, like, does this person need to go to laparotomy? Do they need a pelvic binder? Do they need chest tubes, et cetera, et cetera? So on the basis of the EFAST, they found in these 510 patients that based on that FAST result, 493 of the decisions were correct. That was 97% agreement. And so they advocate for the use of EFAST in having good sort of clinical decision characteristics, clinical decision-making characteristics for the physician. And I agree with that. I think that the FAST can be very useful. In studies before this, they discussed the EFAST being a good rule-in test, but not a great rule-out test. In this study, their conclusion is, the EFAST can be both a good rule-in and a rule-out, and I disagree with that. And I disagree with that because there are still injuries that can be missed early on. We need to know the limitations of FAST. So retroperitoneal bleeds, we cannot see on a FAST. Early bleeds, when they haven't accumulated yet, we cannot see yet on a FAST. So I think it is a great tool, and it shows that it has good characteristics, but I don't think it's a rule-out tool the way that the authors are discussing.
100% agree, yep.
No,
go repeat the question just so you can hear it.
Yeah, so the question was transcranial ultrasound, is that just to look for skull fractures? And the answer to that is it's a measure of blood flow. And they look at it in order to see, is there a bleed? It's also been used for stroke and other things. We don't use it in our ED frequently. I don't know if anybody does, but that's the idea behind it.
I don't think it's very common in the US to use it for that application. The biggest utility, honestly, for a FAST exam is to be able to rule in those life-threatening things. So it's tamponade, right? When you do that view and you can see there's fluid, that you can stick a needle in there before they go to CT, that's where it's most useful. It's to rule in those life-threatening diagnoses that you can do an intervention before they go over to pan scan and disappear into the abyss for 30 minutes, right? It's not necessarily to rule out a pneumothorax. There's going to be things we see on CT that we don't necessarily see on X-ray or ultrasound, but those tiny little pneumothoraces, those don't really matter anyway as far as kind of the stability. So that's, I think, the teaching point of this, of where it's used to really help rule out those diagnoses. All right, the next one, number 7, I thought we had answered this already, but I'm glad that they brought it up again, is does pre-hospital IV fluid benefit major trauma patients?
No.
How many patients, I remember from when I trained in residency, right, EMS would give them like 3 liters of fluid, they were hypotensive in the field, they were 70/30, and now they're 120/80, and we all feel great about that number. Well, it doesn't make sense, right? If I'm bleeding, I'm hemorrhaging, I'm losing blood, if you stick me with 3 liters of fluid, right, you're diluting out the 2 red blood cells that I have left, right? Now my hematocrit drops even more. It never really intuitively made sense, but it made the number look better, so we felt better. And so this is a study that looked at a systematic review of, can we combine these studies and see what is the impact of IV fluids in trauma patients who come in who are hypotensive. So this was sort of a systematic review. It had 6 observational studies, only 1 randomized controlled trial. That was the very famous one out of Houston, and is really the only study that showed harm from patients who got IV fluids. All these patients had systolic blood pressures less than 90, and when they combined and mixed all that data, they found essentially that there was very weak observational studies that standard fluid resuscitation had no benefit on really mortality. And there's data now that RCT that suggested that it actually may be harmful, that we should be okay with this kind of concept of permissive kind of hypotension, that having a 90/70 blood pressure may not be the worst thing in the world. And if you're going to give them anything, maybe we should be giving them blood products as opposed to giving them IV fluids and diluting out those red blood cells.
Yeah, this is such a good rule of thumb for trauma. When you're reaching for a bag of something, you go for the red, not for the clear. And the reason for all of this is one of the major tenets of trauma is we want to prevent trauma-induced coagulopathy, and we want to restore hemodynamic volume. And so when you reach for the fluids, we are diluting all of their coagulation factors, and patients tend to get worse. Even though you're giving them volume, they're not getting the coagulation factors that they need, which is the same reason why when trauma patients, we're going to talk about this in the next couple papers about whole blood, we can't just give packed red blood cells for trauma because they are missing a vital component of FFP and platelets to replenish their coagulation factors. So in trauma and bleeding, when they're hypotensive, we really need to be reaching for the red and for the blood and not the fluids. And so the next few papers all talk about now the nuance of that. Should we be doing whole blood? Should we be doing component therapy? And how early should we be giving the blood? So the next paper is on pediatric trauma transfusion, and it discusses how early do we need to be giving the blood. This is a paper that was done out of Pittsburgh. It was a chart review looking at 50 hospitals in a trauma registry. And the clinical question they were asking was, if we know that patients do better when they get blood earlier in their resuscitation during trauma, but how early should we be giving it? Is it beneficial to the patients if they get the blood in the pre-hospital setting rather than waiting until they get to the hospital? And so here they looked at about 560 trauma patients, kids, who had transfusion requirements, and they looked at in-hospital mortality based on whether they got pre-hospital blood transfusion or transfusion in the ED. This was not an RCT, this was just a retrospective chart review looking at this, so it comes with all those limitations. But what they found was the mortality, the overall mortality was lower, and the in-hospital mortality was lower in association with getting pre-hospital transfusion. 16% versus 27% mortality. In-hospital mortality was 21% in the pre-hospital group versus 32%. The confidence intervals are wide. These are all associations. This is not a trial. It is hypothesis generating, but it is an interesting question of whether or not we need to be revamping maybe potentially some of our EMS protocols, maybe for prolonged transport times for EMS to be able to give blood. Now, again, it's not a trial. We shouldn't be revamping entire EMS systems based off the results of this trial, but it does bring up a question of the potential benefit of giving transfusion a little bit earlier. Question? This was at Pittsburgh, and they were looking at their trauma registry. So this is generally the trauma centers in that area. But it does bring up that so the question was, is this study done in big sort of trauma centers, or was it done in non-trauma centers where they would have gotten transfusions? And this was in Pittsburgh. This was concentrated around the trauma centers in Pennsylvania. But it does beg the question of, I think that's the exact question, if you're in a rural setting and there's prolonged transport times, could that be sort of an intervention? That's one of the questions that comes to mind.
We did a paper last year that looked at transport times in adults and transfusion, and they found sort of this magic number of 30 minutes, that if your transport time was less than 30 minutes, they didn't see a mortality benefit, but if you had prolonged transport times of over 30 minutes, they did start to see a signal that there was some mortality benefit. But how many people here, if it's your kid, it's your grandkid, and they're coming in with hemorrhagic shock, I'm like, give them the blood, right? I think that seems to make a lot of sense, that if they're exsanguinating, that we should be addressing kind of those needs. So number 9, I'm very proud of, because it's my institution. So this is Brooke Army Medical Center, and this is looking at whole blood. And this is something our hospital, the military is a little bit more advanced with this, because when we go into combat zones in Afghanistan and Iraq and we have soldiers who are bleeding out, we don't have a blood bank. We don't have a CT scanner. We literally have a tent and an ultrasound machine, a scalpel, and very limited supplies. And so we do kind of a whole kind of auto transfusions where we can't break blood down into its components. And I used to think that if you took a unit of blood and you spun it down, right, you have your platelets, you have your kind of your coagulation factors, your red blood cells, that one bag of whole blood was equivalent to each of those components if you gave them separately. And it's not. Each of those individual components has dilutants, it has chemicals, it has preservatives, it has extra fluids. So if I gave Ramin a unit of whole blood and I gave myself the equivalent of that of 3 different component therapies, I'm actually getting a lot more fluid and other stuff that I don't necessarily need. And theoretically, there's a lot of benefit to doing whole blood. One, with FFP, you have to thaw it, right? You have to use the blood bank. If I'm getting 3 different units of something that triples my risk of having a donor reaction. And then you have all the stuff that you may not necessarily need. And so the question we've looked at for years is, what is that right ratio? And we know from the proper studies that as much as you can get 1 to 1 to 1, but wouldn't it be great if we didn't have to do ratios? You just gave whole blood, right? And the patient's exsanguinating, they're losing whole blood. And so this was their raw data. So this is not a randomized controlled trial, and it's important to note they didn't even do propensity matching. They just looked at, in our hospital system in San Antonio, all trauma patients that come in now, we changed about 3 years ago, where we don't do component therapy. We don't give just red blood cells. We give whole blood. And so this was when the study first started, and they looked at about 1,000 patients who got your typical just component therapy versus when they only had about 170 patients who got whole blood. And they looked at, kind of what are the signals? What does this sort of look like? And they found that people that got whole blood to start with tended to have a higher shock index, meaning they had a faster heart rate, they're more tachycardic, and they're more hypotensive. But the group that got whole blood, by the time they got to the emergency department, tended to have a lower shock index. They received less frequent massive transfusions. No mortality difference, but again, these are not adjusted. We didn't look at injury severity score. They didn't adjust by age. They didn't adjust by other things. So this, to me, looks really promising and seems to be a very logical response. And I know now Colorado is doing this, San Antonio is doing it, so I think we'll have more data in the next couple of years.
Yeah, and it's important to note that right now we're not at the place where we have really good data, because in theory, whole blood therapy should be better, in theory. And the hypothesis would be that whole blood therapy, for all the reasons that Gillian mentioned, on top of all the logistical things, like we're at a level 1 trauma center, doing component therapy. We have these massive transfusion protocols where they put everything in a cooler and they hand it down to us. So you get the FFP, the platelets, and the red blood cells shipped down to you, and you're ready to go to be able to give everything 1 to 1 to 1. But the problem is, so like if you're not at a level 1 trauma center, you have to thaw for 20 minutes. Even if you have it ready to go, you have to give it in a certain way. There's all these logistics and making sure you're following the protocols. So there's all these barriers. Whole blood therapy would just be so much easier. At our shop, the FFP, and then there's the matter of waste. With whole blood, that lasts, I don't know at your shop how long you hold on to it, 21 days? 20,
yep,
yeah,
21 days.
About 21 days. Once they do the thawing, you only have, a lot of places will, after 24 hours, you gotta discard the FFP. At our place, we've extended it to 5 days. So our blood bank discards the FFP after 5 days. And so you lose that blood product. So there's a lot of reasons, and I hope that this whole blood, sort of the train for whole blood actually pans out and we start to see RCTs so that we can use it more broadly. We're involved in a trial called the Troop trial, and so that's a trial that's coming up. It's a 14 multi-center RCT looking at this whole blood therapy versus component therapy.
So for time purposes, you want to just give the one-liner
Yeah.
on 10 and we'll sum up?
For sure. So you start. Number 1.
So we're to kind of briefly just give the high cap. What do we need to know? So article number 1, trauma activation fees are expensive, higher costs associated with community hospitals, West Coast, and level 2 trauma centers.
Abstract number 2, emergency physicians and trauma physicians do just as well in terms of mortality outcomes for patients when leading trauma teams.
Alcohol and drug use can affect your vital signs, but they should not be a reason that you attribute those abnormal vital signs in trauma patients.
Abstract number 4, our physical exam is limited in identifying life and limb-threatening injuries, but it does not mean pan scan, everybody.
Overall, sadly, our gestalt overall for assessing trauma patients is not as good as we had hoped, and this may support some of the literature in being more conservative with pan scanning and testing things because we're not generally as good as we thought in low-risk patients.
Abstract number 6, the EFAST seems to have nice performance characteristics in identifying interventions in trauma, and also the French do a more comprehensive EFAST than we do.
As far as pre-hospital fluids, don't do it. They don't need saline. If patients are bleeding, they're exsanguinating, have hemorrhagic shock, give blood products.
Abstract number 8, pre-hospital pediatric transfusions. There is an association with decreased mortality, but it's hypothesis generating and more RCTs need to come.
Generally, more data is needed on whole blood, but the kind of initial studies look promising that component therapy may not work logistically as well as whole blood, and the data suggests that, at least in hypothesis-generating studies, that there may be decreased mortality and decreased blood transfusion requirements with whole blood.
And abstract number 10 we didn't get to, but that is whole blood for TBI and shock. There's also an association with potentially decreased mortality in a subset of patients with traumatic brain injuries, but that also hypothesis-generating and RCTs need to be done. All right, thank you.
Thank you very much.